So I want to welcome you officially to the Seattle AWIS October program. My name is Retha Weeks, and I am the Seattle AWIS Treasurer and Board Member. And I think we're very pleased to be co-hosting this program with American Chemical Society Puget Sound Section Women Chemists Committee. And so we have a representative here. So if you had a chance to visit their table, you had a chance to meet at least one of their many members. So Seattle monthly programs are open to the public. They're free of charge. We invite scientists and non-scientists, men and women, and students on all levels of professional life. Our goal is to bring people together because we really do believe in the importance of getting people to meet each other and share ideas. So tonight we welcome those of you that are here in person, but I also want to welcome those of you that are joining us by Zoom. We're glad that we are able to offer both options because we think our programs are worth spreading and sharing widely. So we also believe that the first step in getting to know each other is having a conversation. So we're going to do a little survey, and this will help each of you know each other, get to know each other better, and it will give our speaker a chance to see who's in the audience. So I'm going to ask each of you in person to raise your hand, and online, if you're in the gallery view, you may be able to see people with their hands raised. So the first question is, how many of you are AWIS members? How many of you are ACS, American Chemical Society members? Okay. How many people work in the field related to our program, such as psychology, behavioral sciences, social services, or treatment development? Excellent. And how many of you are here because you feel like you need to learn a lot more about opioid use and treatments? Certainly that's where I fall in. Okay, well, we have a good mix, and we hope that you had a chance to meet a few people before the program started, and I invite you to stick around afterwards because there will be more time to chat, and our speaker has agreed that she can stay a little bit afterwards, so to chat, to have more food, and to get to know each other better. So at this time, I would like to introduce Tracy Popowicz. She is the Seattle AWIS president, and she's going to tell you a little bit about AWIS. And after Tracy is finished, you're going to hear from Despina Strong, who is our representative from American Chemical Society. Tracy.
Thank you, Retha, and welcome to everyone here tonight.
Okay. We had it working. There we go.
Maybe, okay. So most of you who are joining us tonight may have heard of AWIS or are members of AWIS, but for those of you who don't know too much about us, I just wanted to add a little introduction. So National AWIS is centered in Washington, D.C., where the national office is, and it's been active since 1971, working as a resource, network, and voice for women in STEM, technology, engineering, and math. And our success has become spread nationwide with all the different chapters that you can see here with the orange arrowheads. So AWIS's mission is to champion the interests of women in science, technology, engineering, and mathematics. And we're working for positive system changes that will support women in these fields and allow them to achieve their full potential. And here at Seattle AWIS, we're supporting the national mission, but we've been active since 1985, and we're also focused on creating a broad, interdisciplinary, welcoming environment to support the careers of women in STEM, and also to promote the participation of girls in the sciences as well. So we have several programs that contribute to fulfilling this mission. So we have events like the one that you see, the one that we're having tonight. And as Retha mentioned, these are open to the public. They're typically from September to May. And we sure hope you'll enjoy this program and will join us for next month's program as well. We also offer what we call a GEMS program, GEMS standing for Girls in Engineering, Math, and Sciences. And it's a program to encourage 7th and 8th grade girls to become interested and participate in science within school. And then we typically offer a mentoring program, and our mentoring groups are for adults. And we work with groups of 5 to 7 women who are committed to meeting monthly and supporting one another. So we're currently looking for volunteers to help with our mentoring program this year. So I hope someone on the call will be listening and think that that's something that they'd like to find out more about. So if that's the case, please just send a note out to Retha, myself, Tracy Popowicz, or our info@seattleawis.org email address. We also offer scholarships, and these scholarships are for women who are majoring in STEM fields and range in amounts from $1,000 to $7,500. And these scholarships are recognized at our awards and banquet evening that is happening this year on June 17th, 2025. In addition to recognizing the scholarship winners, we'll be giving awards to women who are leaders in the field. So if you're interested in getting involved, there's several ways to do that. So you can find out more information at our website, seattleawis.org. And you can also become a member at this address here, awis.org. And then we're always looking for new volunteers. Specifically, it'd be great if we could have help for the events program that we offer, publicity and website, and then as I mentioned earlier, the mentorship program as well. But if any of these programs spark your interest, just let us know. Additionally, you may be interested in funding a scholarship. That's another way that you can help Seattle AWIS. We also have several social media groups that you can join and be part of our conversation. So the email address to contact is info@seattleawis.org. And then we're accepting nominations for the 2025 Seattle AWIS Awards. And more information on this can be found on our website, but we're going to have 3 award categories: science or technology advancement and leadership, early career achievement in STEM, excellence in STEM education and outreach. And our nomination process is described on the website, and our nomination period will begin November 1st. So that's coming up. So please start putting your thinking caps on and thinking of individuals that you'd like to recognize in one of these categories. And again, you can take part in our awards banquet on June 17th, 2025. And next, it's Despina. Thank you.
Thank you. Is it too loud? I'm a little too loud. Okay. Despina Strong. I'm with representing the American Chemical Society and in particular the Women's Chemist Committee. And first of all, the American Chemical Society is probably, if not the largest scientific society in the world, approximately 150,000 members. We are organized just like you in chapters. We call ourselves local sections. There are over 180 of them in the United States and Canada, and about over 30 international chapters. Our chapter is called the Puget Sound section, and you think that would just be Puget Sound, but we're the orange on the map over there. We actually go into British Columbia, down to Centralia, over to Eastern Washington, serving over 15 four-year colleges, over 27 two-year schools, and all of our other 1,200 members. So that is not easy to do, but we do our best. We have an executive committee of 21 members elected and appointed, and 6 standing committees like a Younger Chemist Committee, Senior Chemist Committee, and the Women's Chemist Committee that I'll be talking to you more about. The Women Chemist Committee, I'll be talking a lot more about the National Committee, the chair of the Puget Sound WCC, but I'm also a member of the National Women's Chemist Committee, which is one of about 30 committees at the national level serving the members of the society. You know, the local committee pretty much doesn't support and mimics the national committee. 2 years ago, we did a new strategic plan, and you can see here our vision is to have equal representation and influence in the chemistry enterprise. We have 3 major goals, working on programming and activities that engage and empower women, recognize and award women. And the one that's highlighted yellow is the one that I'm the project manager for, and I'll be talking a little bit about all of them. Pretty much we do a lot of events, networking events, collaboration, etc. And this one's I'm showing here more of the social level type events, which are equally important, but we do organize quite a few technical symposia. Many of our symposia center around either women issues like sexual harassment, gender equity, as well as celebrating award winners from our various awards. Recently, one of our emphasis has been to, knowing where our members are not really just at our national meetings, but they're in regional meetings and they're in local sections. They're basically in Seattle and in every other city. They're not just going to a national meeting once a year. So we've instituted mini grants to support the local sections. I'm preaching to the choir when it comes to AWIS, I think. We have a lot of overlap, and that will come into play towards the end of my introduction. Women are not getting recognized. If you don't see it, you don't become it, right? So we have over 60 awards, national awards, at the national level, about 46 very prestigious technical awards. And in 2017, we found out by looking at the data that 17 of those awards had never been won by a female. Through a lot of advocacy from our board of directors and our committee, we now have bridged that gap. And we promote nominations for women. If you don't nominate women, and you don't think about nominating them. So I will tell you a really lovely, happy story. And some of you may recognize Nora Disis. She's receiving a national award. That was back in March at the Fancy Banquet. I met Nora in 2022 at the AWIS banquet. She was one of the award winners there, and Rita was very kind enough to introduce me to her afterwards. I met with her and her director, and she got nominated, and she won the Creative Invention Award. So this is how it works: partnerships, allyship, and recognizing somebody out there in the community and nominating them for awards. We also manage about 5 other WCC awards, undergraduate students, graduate students, as well as mid-career scientists. Many of those awards are funded by pharmaceutical companies. Then the last goal I'll talk about that I'm involved with, I'm very excited about. We are spending a lot more time thinking about this area. There's a lot of barriers. People, whether they're women or some other underrepresented group, sometimes is the systemic barriers that are in their way, not their capabilities. So, for example, now ACS offers childcare for during the national meetings. The meetings and expositions committee makes sure that the venues that we go to have gender neutral bathrooms. They offer breastfeeding stations and things like that. And those are things that we've been advocating for many, many years. Sexual harassment medication, something we've been paying attention to more since 2018. We administered one survey to 40,000 members. We're about to send another one out, and as long as we get it through the legal department of ACF, which I'm sure we will. We learned, as you may know, a lot of the most vulnerable population is graduate students, graduate female students, and we're looking into that a little bit more. The last thing that we recognize, and it's not last and it's not least, is partnerships. You can't do these things alone. You need to have allies if you're an underrepresented group, women or other minorities. And have allies, women, we have a lot of male allies on our board. And I'm very, very pleased to announce that in the last 6 months, the Women's Chemist Committee has we've gone out and formed more formal relationships and partnerships with over 10 different other committees or external organizations to ACS. In August, we met with Meredith Gibson, and we are forming and beginning a formation of a more formal relationship with AWIS as a committee, as a national committee. The low-hanging fruit is, do joint events like this one. We've been doing this in Seattle for many years. The Bay Area, AWIS, ACS has been doing it for years. We want to do this nationwide and find ways to collaborate and support each other's mission because there's a lot of overlap. And you can find us everywhere if you're interested to follow us, and we'll be promoting the AWIS events. We have been doing it, and hopefully we'll get to see many of you in future meetings. Thank you.
Okay, it is now my pleasure to introduce our evening speaker. Our speaker is going to be Dr. Mandy Owens, and she's going to be speaking on opioid use disorder and its treatment in a time of fentanyl. So according to CDC, the number of opioid-related deaths has been increasing since 1999, except for a small decrease from 2021 to 2022. CDC says there's been like 3 waves of deaths, and they correlate with different types of opioids. And those different opioids are prescription opioids, heroin, and now fentanyl. So we're going to be hearing a lot more about drug types, about their effects, and more importantly, about the treatment for these opioid overdose uses. So Dr. Owens is an assistant professor in the UW Department of Psychology and Social Science, Behavioral Sciences, and she specifically works in the Addiction, Drug, and Alcohol Institute. So her work aims to improve services for people who use alcohol and drugs, and her focus is on their involvement with the criminal legal system. So I've asked Dr. Owen to tell more about her education and career path because it'll be a lot more interesting coming from her than from me. After Dr. Owen finishes, we will be opening up the floor for questions. So please jot them down during her talk. We'll take questions from those of you that are here in person, but we will also be taking questions from those of you online. So put those questions in the chat, and then we will bring them forward to our speaker. So at this time, Dr. Mandy Owens.
Guessing I should stand in front of the microphone in order for the folks online to hear. Okay. Great. Yes, so it is so lovely to meet you all, and thank you so much for the invitation to be here. So yeah, as Rita said, I'm an assistant professor in psychiatry at the University of Washington. I actually did my undergrad at UW. I was in biology and psychology. I thought I wanted to go into neurobiology because I was interested in understanding why people think the way that they do. And so then I just happened to engage in psychology and kind of almost flipped on to the other side of it. Then I took a class on alcohol and drugs, and I've been hooked ever since, is what I say. So I did my graduate work in psychology, clinical psychology at the University of New Mexico, and then came back here for internship and postdoctoral fellowship at the VA. And then I'm very happy to be back at the University of Washington as faculty. So I'm mostly research, 80%, and then one day a week I see patients specializing in substance use. So that's my area of focus. So, I mean, these are kind of the objectives of the presentation, to talk about the different effects of drugs like fentanyl. What does that look like here in our state? And then really, what is the evidence for medications for opioid use disorder? You are welcome to save questions. Also love questions throughout the presentation if you're interested in it. There's a lot more information that I could go into for each part. And so this can be a choose your own adventure kind of presentation if folks are interested in a particular topic. So I'll kind of start off by giving some foundation information about the different drug types and what their kind of effects are. So these are, in general, going to capture most of the different types of substances. So guessing folks are familiar that stimulants, these are the things that activate the autonomic nervous system. So things like cocaine and methamphetamine. So that's gonna, get people going, breathing heavily, heart rate increasing, sweating, things like that. We also, unfortunately, have been seeing higher rates of psychosis related to drugs like methamphetamine, things like that. Hallucinogens, these include mushrooms, ecstasy, which is MDMA, acid like LSD. Cannabis is kind of its own category. It has some hallucinogenic properties. It also has some stimulating properties and depressant properties. So that's why it's kind of out there on its own. So that's like weed and marijuana, THC. But I'll be focusing mostly on, since I'll be talking about fentanyl, that is an opioid. So depressants, as you probably know, it's not called depressants because they make you depressed, although it can have that impact, developing into something like major depressive disorder. But what it means is that it depresses the body system. So it slows down breathing, heart rate, and things like that. And so people become sedated on them, which is part of the concern with opioid overdoses. Yeah.
Question.
Please.
Are there waves of federal funding that focus more on some types of drugs based on, methamphetamine grew in our country, and then get research that focuses on it? So I'm just wondering if there's disproportionality in those. And probably no one heard my questions, if you want to tell the people online.
Yeah, the question was if there are waves in federal funding based on kind of substance types. Definitely, right? There's a lot of money out there in opioids right now federally because of the high incident rates of overdoses that you just don't even see with other substances. There was more, I'd say historically, probably most money at the federal level has probably been on the law enforcement side and regulation and things like that, compared to NIH or, national institutes like NIAAA, which is alcohol, and NIDA, which is drugs. So, yeah, and there's even increasing funding and allowances to do research on cannabis and hallucinogens like ecstasy. So as I said, fentanyl is an opioid. So other kinds of opioids, there is heroin, which is an opiate. It's naturally derived. Then there's prescription medications. That's like oxycodone, Oxycontin, Vicodin, Percocet. And fentanyl started out as a prescribed medication. It still is prescribed medicinally. It has a lot of uses for things like surgeries and cancer pains. But now the drug market to create fentanyl is extremely efficient, and it's now the predominant opioid on the illicit drug market. I'd even say it's definitely the predominant drug, like of all availability of all substances. It's extremely cheap. It's very potent, which makes it highly dangerous. and it's very easy to make. We've even been hearing about folks who have been lifelong drinking and made the switch to fentanyl because it's so much cheaper than even alcohol. Yeah, it really is kind of upending our entire field from like public health to the healthcare system, that it's like nothing that we've ever seen before. It really has been implicated in increasing rates of drug overdoses, although methamphetamine also is not really talked about in terms of increasing drug overdoses. The other tricky part about fentanyl is that it has a very quick effect. So even heroin, which is pretty fast acting, fentanyl can go up very quickly, and it's lipophilic. So it means it gets absorbed into the fat system, which means it stays into the body for a long time, which just makes it an incredibly addictive substance. And so people, whereas maybe they were using heroin, even on the high end would be something like 10 times a day, now we're hearing people using fentanyl every hour or even more because of how quickly it is acting. Yeah. So across all the different kinds of drugs, there are different ways to administer it, ranging from oral to intranasal, which is snorting, smoking substances like marijuana or cannabis, or smoking methamphetamine, to intravenous drug use. So that is something like injecting heroin. So you tend to see it really depends on the potency. It also depends on somebody's tolerance, and there's a whole lot of other factors. But in general, you see the peak effect. And so that's how high up it goes is going to be highest with IV drug use compared to something like oral. But because it goes up so quickly, it often comes down really quickly. And so if somebody is taking a pill, for example, it's going to be a slower peak, but then stay in the system longer, versus if somebody's injecting heroin, that'll go up and go down quicker. But again, that also really depends on the potency. So as we'll kind of see with fentanyl, there's actually been a switch in the way that people are using opioids, illicit opioids, moving away from intravenous drug use and more towards smoking fentanyl. So what does fentanyl look like nationally and in Washington state? So at least in this national sample in the United States, in terms of alcohol and drug use, so you can see that alcohol, as always, is the most commonly used substance. And then even heroin and opioids are far less common. But like I said, they have higher rates of overdose. So alcohol still kills more people because of the sheer number of people drinking. But opioids, and in particular fentanyl, are more likely to kill persons who are using. That makes sense. When we look at what that looks like in Washington state, so this mirrors the rest of the country. These are probably statistics that you've been hearing on the radio or reading. People listen to the radio, listening, on the news and reading online. And so you can see, as was mentioned, yes, we've had very steady increases in drug poisonings, especially over the last 5 years. And so it's a little bit harder to see the colors, but this green line is other synthetic opioids, so that's going to be fentanyl. This blue line is that methamphetamine. And so, yeah, you can really see that fentanyl has really kind of taken over. And then even heroin has started to come down. And so that's not because heroin is any less lethal, but again, fentanyl has just really come in, and all the drug supply market is fentanyl. Even in the last couple, and that's been in the last couple years, and in a lot of areas, you can't even find heroin. You can only find fentanyl. Although it seems like there is some going back. So that is why you see that dip in heroin. So this is, again, the most common data that gets reported in the media, but there's really a lot more behind what drug use looks like, especially for folks, when we're thinking about our community members. So this is a survey that comes out of our shop. It happens every other year. So I'm in ADI, which is in psychiatry and the School of Medicine. And then I'm in a center, which is a Center for Community Engaged Drug Education, Epidemiology, and Research. And so every other year we do surveys with people who use drugs, accessing syringe service programs all around the state. So the last time we completed it was this last year. So folks were recruited from these programs throughout Washington. It was, of course, voluntary. They got paid. So we were able to interview close to 1,700 people who reported past week drug use. Folks are interested. These are the results of it, kind of summarizing it. So part of what we are trying to do in our shop is not just do research or trying to better understand what it looks like for people who are using drugs, but also what services they want. And then we do a lot of work to get education back out to those who need it, including community members, but also professionals working in healthcare. Or as Rita mentioned, I work a lot in the criminal legal spaces. So I work with jails, prisons, and law enforcement. So we'll go through these results a little bit more in depth. Yeah.
Just curious because this is behavior that's not legal and you're serving, you're asking them about it to report it to you. So could you speak to that a little bit about how you get that information?
Yeah. So how do we collect information about illegal behaviors? So I mean, in the IRB world, this is exempt, and part of the reason for that is because it's completely anonymous. I mean, but these are services that are existing. Unfortunately, there are some communities that leverage that for all the wrong reasons. Law enforcement patrolling those areas and things like that. But there are also public health laws that protect these services and people accessing them. In terms on the research side, the anonymity is how we protect people. If we're doing research studies, when we do research studies among folks using drugs, we can get a federal certificate of confidentiality, which adds an extra layer of research protection for folks who participate, understanding that. So like working with folks in jails or on probation, we definitely make sure to get that because we obviously don't want people to be harmed by talking to us. Yeah. Yeah.
So the people who that you end up seeing because they're telling you or they have to call the medical services, what's the percentage of people who take fentanyl but don't know they're taking fentanyl? They think they're taking something else? How frequent is that?
Yeah, so we've also out of our shop have been setting up drug checking sites around Washington State for that very reason. And so folks can bring in samples and they get tested with things like fentanyl strips or through more sophisticated machines on site, as well as sent in for more kind of confirmatory analyses. So generally, I mean, there's a lot of things in those samples. I could even bring up our website where we show so for samples that were brought in and sold as fentanyl pills, what all is in them. It's never just fentanyl, but it's more likely to be other analgesics like Tylenol and pharmaceutical benzodiazepines, and a lot of other synthetics that are probably more in your world than it in mine, that are just like these chemical compounds that we can't even keep up with. There's one that they've shortened it to BMTS, I think, that has just been found in contaminating fentanyl. We don't even know what it does to the system yet, but we're just seeing it more commonly. Xylazine is another one that has been getting more coverage. I don't know, have folks been hearing about xylazine? It's more common on the East Coast, but it's a veterinary tranquilizer that got a lot of national attention because it causes really severe wounds. Luckily, so far, we're not really seeing a lot of it in Washington State yet, but so if people are reporting that they are getting other substances in their fentanyl, that's probably true. Yeah. And then in terms of methamphetamine, that also sometimes has fentanyl in it, but not very commonly. Yeah. But then that does get tricky because when people are kind of like using the methamphetamine, thinking that that's all they're using, and then they start developing opioid withdrawals or overdose even, then that gets more complicated. Yeah, this is why it's, yeah, research with humans is hard. It's messy. So these are the demographics for this sample of 1,700 folks. And so sometimes I show a map of where they were all collected from. It's mostly on the I-5 corridor, Seattle, Tacoma, Olympia, but we actually have a fair good amount from Eastern Washington or rural in Western Washington, trying to better understand that. So mostly men accessing these services, about 2/3. And you kind of see folks in their 30s and 40s, typically mostly white, overrepresented compared to even some, depending on the areas that they live in. And then mostly people experiencing houselessness. And then just some data on sexual orientation, because we're curious about those kinds of trends. In terms of substances that people reported using in the last week, so we asked them, what drugs did you use in the last week, and what did you identify as your main drug? So it was about equal splits. About 40% reported that methamphetamine was their main drug, 40% reported that fentanyl was their main drug, and then a smaller smattering of other substances. Most people reported using any methamphetamine in the last week. About 2/3 or just over half reported using fentanyl. Again, cocaine maybe rate increasing, and then fewer of these other substances. When we ask them, how much are you using in the last week? So you can see that on average, people using methamphetamine are about using 6 days a week, similar to fentanyl, again, less common. So like I was saying, these are like very highly addictive. And so when people are using, most people are using most days out of the week. When we ask about route of methamphetamine and fentanyl use, so again, that could be either injecting only or intravenously, smoking and injecting, or smoking only. So among folks using methamphetamine, just over half were only smoking, about 1/3 were smoking and injecting, and fewer just injecting. And then for the vast majority of folks using fentanyl, they're mostly smoking it. So again, that's a real shift that we've seen historically. People are more likely to be injecting heroin, but because fentanyl is so potent, they're able to smoke it. Does that make sense? So no longer, do they need to inject it? And there's obviously a lot of drawbacks to injecting, like needing needles and things like that, as well as the risk for bloodborne pathogens. Within our sample, there were no significant gender differences in use. In the broader literature in terms of fentanyl use, similar to other substances, we see greater escalation of use among women, one mechanism potentially being chronic pain as a route. And then unfortunately, this is really commonly seen in other substances as well. Alcohol is where most of my work has been historically, and you definitely see that when women start drinking, they progress to alcohol use disorder quicker and in greater severity. Any thoughts of why you think that might be? our best guess is less likely to seek services sooner, and shame, as well as maybe some biological components, although that's not well understood. So even for women exhibiting greater withdrawal from opioids like morphine, so that potentially could be another reason for escalation of use, but the research so far on fentanyl is mixed. And again, the data on fentanyl are pretty new and kind of still continuing to emerge, because it really only took over the drug supply during COVID. So like 2021 and 2022 really in the western part of the United States. We asked folks about opioid overdose in the last 3 months. It's encouraging to see that 71% said that they did not experience an overdose, but even still, that's 30% experiencing an overdose in the last 3 months, which with 11% experiencing more than 3 overdoses in such a short time period. Yeah.
Overdose is like person falls over, is unconscious. That's the definition.
Yeah, so the way we allow people to we didn't go through the full, definition of what that could be. So it could range from passing out to needing medical intervention. So it could include both. So people falling asleep, but not going into respiratory arrest, as well as folks who might have needed naloxone. So, which is Narcan, if you've heard of it. It's an extremely effective opioid. It reverses opioid overdoses. So when people are overdosing on opioids, so that it depresses the body system so much that people stop breathing. And when you administer naloxone, either intranasally or intramuscularly, it kicks all the opioids off the receptors. And so people will wake right up. It's, quite alarming. People can still overdose again if they have so much fentanyl in their system. You can give them Narcan, kicks everything off, they wake up, 30 minutes later, fentanyl returns back to the receptors and people can overdose again. People who are experiencing homelessness were significantly more likely to overdose than those who reported permanent housing, which probably makes a lot of sense. People are more likely to use alone, which also increases their risk. So our ADAI runs a website, stopoverdose.org. It has more information than you might even know what to do with about opioid overdose. So it includes information and signs of an opioid overdose, what that looks like, great training videos out of the Department of Health, as well as information about where anybody can get Narcan. I carry it, I have it in my car, just because you never know, especially living in Seattle, you see it a lot. But I mean, you don't have to live in Seattle to see it. You can be anywhere, unfortunately.
So is this the medication that they're putting in schools and public places?
Yep. Yeah, anybody, you don't need a prescription to get it. You can go to any pharmacy and get it, which is great. There's also even like vending machines in certain areas. Like we work with some jails that have it for free, just really trying to get it like out there as much as possible, because people are in King County, 4 people die every day from a drug overdose. So it's some downtick in the last couple months, but we think that the downtick in overdose rates is because the number of people who have died from overdose is outspeeding the number of people introducing use. Does that make sense? So it has now killed so many people within that community. That is why it is a smaller sample of people to die from an overdose than are starting to use opioids. Yeah. It's nice to see a downtick, but that's a unfortunate, sad consideration. Okay. So what what are the tools that we have for medications for opioid use disorder and including overdose as well. So Narcan is great because when there is an overdose, that's what you do to keep somebody alive. But in terms of reducing somebody's risk and really trying to bring those numbers down, it's going to be these medications. So what do I mean when I say opioid use disorder? So that's the clinical term that's defined by the American Psychiatric Association. So I use the DSM-5, which is the Diagnostic and Statistical Manual of Mental Health Disorders. So opioid use disorder, it's a biopsychosocial, we say, so it affects people on multiple levels. Non-fatal overdoses happen to about 1 in 5 people with opioid use disorder each year, although that was even data based on folks using heroin, so it's far likely to be even higher now. Overdose deaths occur in 1 to 2% of folks, and even higher for folks who are receiving emergency medical care. Again, probably higher now. These are the 11 symptoms of opioid use disorder. So, like I said, there are biological components like tolerance and withdrawal, psychological symptoms like using more than intended, repeatedly trying to quit or cut down. And then, of course, we have seen or heard about the social problems, the ways that substances can interfere with work and relationships and things like that. And then also in the 5th edition, kind of recognizing that there could be a range of severity when it comes to fentanyl. You see that jump higher to severe, although like it is possible for people to have a mild opioid use disorder related to their fentanyl. That's just less common. And so the reason why I bring up like how we define a use disorder is going to come into play when I talk about the medications. So that's the clinical definition. This is kind of another way to think about opioid use disorder. So you do see this biological or dependence. So when people use opioids, that includes if you're prescribed an opioid, you will develop a biological dependence, most likely depending on how much you're taking in for a regular period of time. And that's true of fentanyl too. And so that includes tolerance. So that might mean you need to take more in order to get the same effect, or the same amount no longer affects you. Or you develop withdrawal symptoms. So if you stop using, your body kind of, you get sick. But then there's this real component of the disorder part of an opioid use disorder, and really thinking about those social and psychological type problems. So when we think about it that way, this is another visual way that you might think about what an opioid use disorder looks like. So we have this very highly scientific y-axis of feeling normal, feeling really good, and feeling really bad. And what this is trying to describe is that when people are new to opioid use, including fentanyl, at the beginning they start using and they feel really good. That's not true for everybody. Some people use opioids and they feel really bad. They get nauseous, but for a lot of folks, they feel really good. And then, it gets out of their system and they go back to feeling normal. And then they use again and then they feel really good. And then over time, this isn't number of days or number of use, but just kind of like over time, what that actually shifts into is people are no longer using and feeling really good. They're now using to just not feel bad. So they develop this biologic dependence, and especially withdrawal from opioids is particularly terrible, that people are just using so that they don't get sick. And so they end up on this really rocky roller coaster of chaos with their use of just like up, down, trying not to feel sick. That kind of keeps them locked in. And I try to show this too, because there is often this myth that people who use drugs are just having a good time and, enjoying their addiction. But a lot of times people hate it. They want to get out. They don't want to feel sick anymore. It's just, they feel so terrible if they stop using. And so that's part of where recovery can really come in with medications because of, especially with opioids, the way that these medications impact the body, it takes people off the roller coaster and puts them into this range of normality. So thought a different way. So when you take medications for opioid use disorder that are agonists like buprenorphine and methadone, which I'll explain, people will still have a biological dependence, but they don't have the disorder. They're not in this like roller coaster chaos. And so per the DSM, or if you're taking buprenorphine, methadone, prescribed pain medications as prescribed, you might have this dependence, but you don't have the disorder. So, and this is really what we're trying to help people get out of, is that disorder. Yeah.
So I'm new to this field.
Yeah.
So is the point of medication, so do they continue that medication, the prescribed medication indefinitely forever? Like, is that the new way to manage it?
I mean, it's the same thing with like antidepressants, or, it's stay on it as long as you need to stay on a medication. So for some folks that might be a couple months, but the research is really clear that the longer people stay on it, the better their outcomes. Now we hear a lot of stigma, or like you're just trading one drug for another, but really these medications reduce risk for overdose. And again, because they don't have those properties, like especially fentanyl, which is so quick acting, they keep people stable, then people are, able to get back to work and re-engage in their relationships. And that's particularly methadone and buprenorphine. The research is really clear about the effectiveness with methadone and improving quality of life. And again, especially mortality and risk for overdose. Long-acting naltrexone is a third medication for opioid use disorder. It's not an opioid, and the evidence is not there for it. People are less likely to stay on it, and so that's part of the reason why we don't see those effectiveness data. Yeah.
Do we have any insight into why people are less likely to stay on it? That seems like there must be a reason.
I mean, part of what, do we have data about why people don't stay on long-acting naltrexone? So again, that's not an opioid. Methadone and buprenorphine are opioids. We think that part of that reason is because they don't satisfy the opioid receptors the way that opioids do. And so people don't feel normal on it. It's also a pretty painful injection that people don't like very much. And so that's not a winning combination. Yeah. Did you have a question?
Yeah. I'm trying to understand, when they get the medication, they're still dependent. So they're still using opioids, but at the same time as taking the medication.
So methadone and buprenorphine are opioids. So they will still technically have a dependence on an opioid. Just if they are using methadone and buprenorphine, it stabilizes them more. They're more likely to have improved quality of life, decreased risk for overdose, decreased risk for mortality. Have lots and lots of, lots of patients and people who continue to use fentanyl on top of methadone and buprenorphine. I mean, that's how addictive fentanyl is and how strong it is, even compared to these medications. But as long as people have these medications on board, their risk for mortality is cut in half. So like I have patients who are on methadone and continue to use fentanyl, and I would much rather have that than limit their access to methadone or buprenorphine. So it's 7:26. I have a couple more slides on the medications, but I could also kind of wrap up here. Okay. So this is just so that you know, there's so many studies on the effectiveness of especially methadone and buprenorphine that they're not even funding that work anymore because it's the research is just so clear that they work. And like I said, these are really the best tools that we have to treat withdrawal and against the opioid overdose crisis. So this is a brochure that we created and put out to try to provide education about it. So you're welcome to kind of check it out. But I might just talk about the medications really quick. So methadone is what we call a full opioid agonist. So what that means is that the more somebody takes, the more opioid effect that it has, including respiratory depression. So fentanyl's a full opioid agonist. All prescribed pain medications are full opioid agonists. Heroin's a full opioid agonist. Buprenorphine is like this magic drug. It is what's called a partial opioid agonist. And what that means is that it is an opioid. So it also has a very high affinity to the opioid receptors. But because it's a partial agonist, it will create a ceiling effect for the opioid and respiratory depressant effects. And so what that means is that people can continue to take a lot of buprenorphine and it won't lead to an opioid overdose. People can still have an opioid overdose if they use a lot of fentanyl on top of it, but it makes it an incredibly safe medication. Nobody has ever overdosed from just buprenorphine, except for an unfortunate few rare cases of children. So, I mean, that is, again, like why it makes it such an incredibly powerful or like safe and effective tool. And then, as I said, naltrexone is not an opioid, it's an opioid antagonist, which means it blocks the opioid receptors and prevents people from experiencing the opioid effect if they take opioids on top of the while taking the medication. So again, just quickly, methadone, that's the full opioid. It manages cravings and withdrawal by binding to those receptors. It lasts about 24 hours. It's most commonly taken by mouth in liquid form. For the treatment of opioid use disorder, it can only be provided at opioid treatment programs, methadone clinics. It's highly, highly regulated by the federal government. People usually have to start by taking daily observed dosing. That's one of the biggest barriers. People literally have to go to the clinic every single day in order to get dosed. And they have to go through a number of other requirements like urine drug screening and counseling regularly. Buprenorphine, partial opioid, similarly binds to the opioid receptors. Again, when it's taken sublingually, that's under the tongue, lasts about 24 hours, or there is a 2-week and a 4-week injection now, which is, turned generic, which is making it far more accessible. Really, what also makes it accessible is the fact that it can be prescribed by any prescriber out there. So you could go to your primary care physician and they can prescribe buprenorphine. So again, naltrexone, opioid blocker. We're not really sure why it manages cravings, maybe because people know they won't get the euphoric effect if they use opioids. That's the best that we can kind of guess, but otherwise it doesn't act on the opioid system. It lasts for 28 days. It also can be prescribed by anybody or any prescriber. It's not a narcotic, which makes it more accessible. But the effectiveness is really limited by the fact that people don't go back for a second injection on average. I know lots of people, I've seen many patients who have gone and been successful on naltrexone. So the best and most effective type of medication is the one that a patient will take. So if somebody is appropriate for and wants to do naltrexone, absolutely. It is effective. It can help, it'll help protect against opioid overdose by blocking those receptors. And so if people are motivated to stay on it, then absolutely, that's a conversation between somebody and their prescriber. So I have a video with Victor. It's one that he shared with us and just kind of talks about his story. He was 25 years of incarceration in and out of the California carceral system, all related to his heroin use, has now been on buprenorphine for 10 years. And as he says, if it ain't broke, why fix it? So a really inspiring story. So thank you so much.
Thank you.